Let's start with Leuven. Mark, can you hear me? We
Yes.
can't see you
I
yet, but
Okay. Do you see me now? Do you
hi,
see?
Mark. Yes,
Yeah.
Peter.
Hi, Peter. We have a little change in program. I know that there was a VSD scheduled, but I thought it was going to be boring for you. So we did plan something else. We'll present the patient. Can I have the first slide, please? The first slide. So we're going to close an Abernathy shunt. Next slide, please. So this patient actually presented a couple of weeks ago while still in the belly of the mother as a fetus. And on routine screening at 26 weeks, the gynecologist had noted that the heart was somewhat big. And that was the reason for referral. So we looked at the heart, and indeed it was mildly big, but structurally the heart was essentially normal, except for some mild tricuspid regurgitation, and postnatally there is an atypical Epstein something. But what was quite obvious was that there was an abnormal venous drainage from the umbilical vein. As a matter of fact, as the vein entered the belly, it did split proximal in the liver, and one part was going as it should be, up to the hepatic veins and the portal veins and the venous duct, but there was another big vessel going directly to the right atrium. This was a picture that we see. So the vessel going to at the right bottom low, that was the abnormal vessel going directly to the right atrium. Now, I presume that in some of you guys, the knowledge of the portal system is somewhat way back. As you see on this cartoon, from down the bottom, the umbilical vein is supposed to enter to the liver and then connect to a confluence which is connected to the future portal veins. On that region also, the extrahepatic portal vein connects, and the extrahepatic portal vein consists of the spleen vein, so the vena lienalis and the vena mesenterica. And then this big vessel will go through the liver like a big freeway, and the venous duct is actually connecting this confluence to the inferior caval vein. At birth, it is supposed to be that the umbilical vein and the venous duct are supposed to close. In order to get the cartoon on the right side, where the mesenteric splanchnic venous system connects to the portal system, and the blood now first have to go through the liver parenchyma in order to get to the venous system. And so the ductus umbilicalis and the ductus venosus will constrict and become a string-like structure. Now, what we did see in this patient, cartoon on the right, is that the big umbilical vein as it came in, there's a right part, a normal part with a smallish venous duct, and then there was a big freeway going directly from that confluence all the way to the right atrium. And so one can presume that at birth the normal functions will occur, but the big question is this vessel going to close, yes or no? Because if it does not close, this is an escape route for the splanchnic venous blood that can bypass the liver. Now, those portocaval shunts, they have a lot of names. Up above you see quite a few names, but they all result in a few consistent things. First of all, the perfusion of the liver is abnormal, and so the liver parenchyma will not be happy. The fact that there is hypoperfusion will result in reactive nodular hyperplasia, and in time, when adult, it can become adenomas, even blastomas. On the other side, on the fact that the non-filtered blood enters the venous system has profound, or can have profound effects on two systems, especially the lungs and the brain. What the lungs is concerned, it can cause very severe, even lethal pulmonary hypertension in time, AVMs with cyanosis, arterial collaterals, we have a few like those, clobbing, And what the brain is concerned, the brain is not happy with all that ammonia and bad things that you drain from the gut if it's not filtered, and you can get psychomotor development delay and encephalopathia. Abernathy, 1793, did describe it for the first time. There is a lot of classifications which are hard and uninteresting for today. But so, as a child was born, we were watching the liver, and so on the top you see there the right big vessel coming, entering directly into the right atrium. We were hoping this vessel to close because some of these vessels may be programmed like a venous duct and close spontaneously. This sucker, however, after 2 months is still wide open. And so we did additional investigations. Here you see a CT where the vena lienalis and the mesenteric vein come together. They form there the extrahepatic portal vein, and then from there, from that point, actually, you should go back to the point where the bend is. From that point, the normal portal veins with centripetal flow should show, guiding the blood towards the parenchyma, so that it can then go to the hepatic veins. And as you can see, there is a big freeway going from that point all the way to the right atrium. The next CTs show you a sequence. There you see the big vessel going to the liver, and here then the connection with the right atrium. That is not what we want to see in this child. So, what is the intended procedure? I don't read my thing myself. So, but we're first gonna confirm the anatomy and the physiology, and then we're gonna do a test occlusion just to define whether the portal veins are really connected and present. Because if they are not, and we would close that thing, we would blow off his gut. We will see that if we do a test occlusion, that the liver can function at a reasonable pressure, so that means the gradient between the portal veins and the right atrium should be less than 10 millimeters of mercury. And also we would like to define the wall resistance, because that will be our landing zone for an occluder. And if all goes well, we plan to occlude completely or that freeway. The kid is only 2 months old. In theory, it should have more than enough capacity to catch up with that time loss of 2 months and activate its real portal system. In practice, in older children, 10 years, 15 years old, or young adults, that may be a major problem. And if the hepatic portal system is severely hypoplastic, sometimes you have to go through first a partial occlusion and then complete it a few months later with a complete thing. Okay, so that's the theory. Now the practice. Any question at this moment? Can we in the meantime already prepare to show what we have done before so far? The fossil in. Peter, questions?
Where is your access?
Well, from the...
Yes, on the panel there are Eltjana Brokenheimer and Joe.
Okay.
And Eltjana has a question, please.
Okay, when I was looking at the...
How much access do you have? Do you just have the IJ, do you have a femoral as well?
I have femoral as well. I am at the jugular vein right now. And for the CT suggested me that coming from the neck would be easier, and that's why I started, but we have a femoral access present as well.
Yeah, no, I think the neck is a very good approach.
Okay, so here you see...
Okay, Mark, please, go ahead.
Can I have the injection before that? And before? So as we were looking for a vessel, we were not sure, and before, where we were not sure where to find it. You see that we're there in the bottom of the right atrium in a pouch that is not supposed to be there. Indeed, on echo, you see that the rotation of the heart is not the way it's supposed to be, so there is something weird. But okay, coming from up above, we enter the vessel, and you see that where that big vein is coming in. I'm actually right now with the catheter in a paravertebral vein. So we pulled it back, reoriented. No, the next, go forward. We pulled it back and entered then the big vessel. I must say there is a nasty angle over there, and we made an injection over there. So showing that there is indeed portal veins. What is a little bit annoying for me is that there is such an easy connection from that portal vein directly to the hepatic vein. I don't think that is really normal. But I have my hepatologist next to me, and we'll first make better angios with a balloon occlusion, just to give a better visualization of how is the anatomy here of this system. And also, if we occlude it, what I intend to do, is the pressure going to be acceptable for the liver and the gut, yes or no? Any questions so far?
Mark, I have a... Yeah, well, if you look at this angiogram, then you see on the last one, yeah, now you have the wire proceeded in the vessel below this.
Yeah, in the splenic, we're now in the splenic vein.
Can it be that this huge vessel which you entered with your catheter is just a second parallel hepatic hilus, and that these let me say and so it belongs a little bit more to the hepatic veins as on the right side, and that you have to occlude the vessel more to the bottom where you see the efflux of the contrast.
Where the tip is now, where the tip of the catheter is.
Yeah, well, you see this backwash of contrast,
yeah,
of a very big vessel, which you still which you have not entered yet.
Wait, we're in it right now. Actually, that vessel, next wire. So we were probing at the wire, and as you see, this wire has gone all the way to the left. I think it's in the splenic vein right now. Yeah, it's with a prograde that we're doing. Correct. That. So we're following it up. I've exchanged it for a stiff 0.014 Ironman, and actually that's where we are right now. So it was my intention now to advance a balloon occlusion catheter and make a nice angiogram under occlusion of that abnormal shunt, just to define better the anatomy and see how things look like.
Yeah. Well, Mark, why do you think it to work? We have a congenital portal systemic shunt clinic in our hospital. We've done 16 cases. So just in general, we like to, first of all, inject through the SMA on digital subtaxial angiography, and that shows on the levo phase, you can normally see the anatomy very well. And then we do the occlusion from above, as you are doing very nicely. And it's very important in these cases to balloon occlude the drainage so that you can show all the portal system. However, here, I think that this is an Abernethy malformation with some portal vein hyperplasia, with left venous portal hyperplasia more prominent, but it has a number of drainages. I think it has multiple drainage. So that vessel won't close, and you may be able to close it, or you may have to reduce it. And when it comes to reducing, then we can open it up to how to reduce it, but we have a very simple method for doing that. So the important thing now is to get a big balloon, like a large tie shack balloon, down into that. And I would do it at the top, not at the bottom. And I think you'll see very nicely that you have multiple drainage on from the right anyway, which is, I think that's a true portal vein there.
Yeah, but it gives a connection a little bit too easy to... I didn't like... so in the meantime, I did put a flexor sheet in the vein, just so that we can push better also with the tie shack balloon. Haalt die maar uit. Hebben we een 10 mm? Door welke sheet gaat dat? Door wat gaat dat?
Size your tie shack balloon will be, Mark? Which size do you intend to inflate?
Well, I wanted to have a 10.2, but we ran out. And so it will be a 10.3, which is a little long, but okay, it will do. It will do the business. Geef die maar.
Okay.
Okay. So there
this is Jose Luis from Madrid. I'm completely agree with the rest of the panelists that one of my main worry when I am working in this kind of venous shunt is what happened with the outcome of the patients, because I don't know if anything about the development of the venous portal system. For this reason, we prefer to close with a conventional regular plug without fabric inside in order to obtain a progressive close and no close suddenly. In this form, perhaps you could obtain more time for the normal development of the venous portal system. I prefer to close with a regular plug without fabric, and perhaps delay the total close of the shunt, perhaps 2, 3, 4 months.
Yeah, well, it's. I think that in this patient, we have the very special feature that he's very young. Yeah. Actually, this patient right now is completely asymptomatic, full stop. You don't see anything about him. It was just 4 twitches that we saw, that we intercepted him during fetal life. But I think most of the people that know about this hepatic pathology will recognize that this patient is a very good candidate for developing very serious trouble in time if we don't close or if we don't do something right now. And closing it later will only make life more difficult. In other words, theoretically, what we are doing right now should have happened 2 months ago with the venous duct closing. I don't know how fast the venous duct closes, but I think it does that within hours after birth, something like that. I don't know the real time course of the venous duct. Right now, I'm quite confident that if we close it, that the normal hepatic venous portal system will develop as it should be. But what I didn't like is why my first angiogram, which showed that there was significant runoff towards the thing. Well, we're first gonna inflate the balloon just to see what's happening. Okay, I push on it. Okay. And now you take a, sorry, zet er eens een draadje, een driewegkraan. Fix it. Okay, fix it. And then, do we have a Y connector? Get a Y connector. We're still in position. So you see, it can, the proximal, I mean, the atrial side of that shunt, this is now a 10 millimeter balloon, can be stretched easily. The only indentation we see right there is, wait, I'll film it so that we can measure, make nice measurements. Can you measure at the distal part of the balloon how big that is now? Okay, and can you make an angio? Door the balloon. We're just putting a Y connector on the lumen, and so we'll try to make a nice angio with the 0.014 catheter still in position. Well, we probably may have to de-air it a little bit. Okay, just inject. Okay, that looks all right. Ready to make the good injection? Wait, center more on the left side. Center the table, please, more on the left side. We're working here with 4 hands, just seeing what's going on. More like this. Okay. And zorg dat je kunt. We'll make an angio. That doesn't look too bad. I mean, it goes away, and you see flow going through the liver parenchyma, going to the hepatic veins. We'll do it again under subtraction.
So Mark.
Yep. Krijgen wij zo meteen apnee?
I don't think you need to under subtraction, because this is more like a Medusa approach where the portal veins have multiple connections. So I think that if you close this, you're not going to get portal hypertension.
Yes.
What you can do is you can take out the wire through the chewy balls. You can measure the pressure and let the balloon down and see what the pressure goes down to. But the advantage here is that you have a neck and that you have multiple drainage. So even Joseph's point is, if this was the sole drainage of the portal system, then you would have to close it in a staged way. And I agree that you can do that by taking out the fabric, or you can put in double-barreled stents or bow tie stents, and all different types of ways of doing it. That's just a technicality. But here the physiology is what's a fascination. So I think you should tell us the pressure when you have the balloon occluded now, and then let the balloon down. And if the balloon is not, if the pressure is not above 18 millimeters of mercury, then you can safely close this, probably with an AD01, just a large AD01, and hook it under that ridge there.
Ja. Nog even wachten. We're just hooking up now for the pressure. Kun jij volgen? Or do we have an extra line, an extension line to get here? We have another druklijn. We have to connect our pressure measurement. But in the meantime, we'll do the subtraction angio, just for completeness. We have the time, and we have time for... wait, I'll just check it. Okay, are we ready for subtraction? Ready for subtraction? Okay.
Before you do that, Mark, do it.
Just a second. Can we have up name?
Because otherwise it's very difficult to read.
Can we have, yeah, up name? Doe maar. So it shows a good runoff. Okay, ventilatie. It shows good runoff of the vein, but we're going to measure the pressure. We intended to do that anyway, and so as a rule, an unwritten guideline, it says that when you occlude these vessels, you should aim to have a gradient between the portal system and the right atrium of less than 10 millimeters of mercury. So we're connecting to the pressure. So the pressure right now is it's a mean of 14. It's a mean of 14. That's not too bad. And we will deflate the balloon. We will deflate the balloon right now. And can you see the pressure? No. It goes down to 11, the mean. It goes down to 11, which is not bad at all. We can.
But I can tell you that without even looking at.
So it was.
As long as it's less than 18 millimeters of mercury during occlusion, you can safely occlude the vessel.
Okay. So also with that guideline, so we had 15 with occluded, and the sheet. Well, we can't.
Okay. So there's a question of the auditorium. Can we have the microphone on for the first microphone in the aisle there for Dietmar Schwanz? The microphone in the aisle, please. Hello, technicians. So Mark, in the meantime, have you any plans what kind of occluder you would like to implant there in these 10 millimeter diameter measuring vessel?
Well, so right now I have a 5 French flexor sheet
Mark,
in position.
you can hear us?
Yeah, I can hear you. Can you hear me? Can you hear me?
No, we have some problems with the acoustic. Here's a question from Dietmar Schwanz. Dietmar, please.
Hello, Mark.
Hello.
I learned a lot in Gießen from our veteran cardiologists. They have a husky every week, once or two, and they have is a husky, a dog, eating, and then he becomes dizzy. Then you have the diagnosis, ductus venosus persistens. Very nice. And I learned by him, like Peter mentioned, more than 15 by occlusion. Make and put flow reducer in, and you can create very nicely a flow reducer if you have maybe a covered stent and put a 5 millimeter or 4 millimeter coronary stent around, and then put it in and close it in 3 months. That is what I do in this patient. Thank you very much for your attention.
Well, let's put it this way: in the older patients where I've done it, we indeed. Draadduwen, push on the wire. Indeed, there I would go for a sequential closure. But again, this kid is only 2 months old. If the venous duct would have been normal, it would have closed 2 months ago, a natural process. And I think that the portal system does not look that high. It is small, but it is not that bad. Second thing is that goed op het wire duwen, hè? Yeah. Second thing is that The second thing is that there is runoff. There is runoff even more than I anticipated, and that tells me that this Abernathy is probably not the only one, and that we may have to come back in any way, but to close the other ones. That's not for today. So there will be already runoff. And then the third thing is we did the pressure measurement. The rule from El Canan was 18. My rule was gradient less than 10 when you inflate the balloon. Both criteria are fulfilled, so I think we can go for the easy solution and completely occlude this at this time, and then reassess in a month or so to see what the liver has been doing.
We have to speed up a little bit. San Donato wants us in 5 minutes, so please tell us. You have now 5 French braided sheath in this vessel, and what type of occluder you plan to implant?
I'm still thinking. I'm gonna make an extra angio with the sheet now in place. Here, wait, let's see. Okay.
Let's ask the audience. Shall I make a proposal?
Sure.
What about an AVO2?
You can put an AVP in there.
With, let's say, the smallest part is 8 millimeter with 10 or 12 millimeter in diameter.
I was planning on daar rechts onderaan de 12. Wait, I have to go and look myself a little bit at the chart, because the 5 French sheet, see what fits the 5 French sheet. 10, 12. We'll go for vascular plug 2, 12 millimeters, 9 millimeter length. It fits a 5 French sheet, it should go in there.
Are there any serious objections from the audience to take an AVP2 in this situation with 12 millimeter in diameter? I don't see any objections. So, Mark, we are all your opinion. And, well, perhaps we can give you a little bit of time to prepare everything, and we go to San Donato so that they can introduce us in their case and come back to you as soon as you're ready to place the device. Is that okay with you?
That's perfect, thank you.
Okay.
Is it nog altijd in place?
Okay, so then take your time.
One final comment, Mark.
Yes?
Put the device as close as possible to the heart, because you don't know where the left portal vein comes off. Okay, you can't see in this view where the left portal vein comes off. And it's probably better doing an LAO cranial view when you do the positioning and see if you can see where the left portal vein comes off. That's the most distal part. You don't want to block that off, side branch, block that off with the device. Okay?
Perhaps we'll have some time for discussion when the occluder is about to be placed. And Mark, thank you so much. It's a very interesting case. Good luck, and we are back to you in a few minutes.
Okay, thank you.
So, Mark, can you hear us?
Yes? Can you hear me?
Hello, Mark. How does it work?
Okay, what we have done in the meantime, so we took our second
Mark,
line.
can you hear us?
Can you hear me? Can you hear me? And show the fuss, the A, B. Can you hear me? Peter, can you hear me? Okay, we will, the fuss.
Yeah, we can hear you.
Okay, the
Please
radio.
what did you do, and how does it look like now?
We took some extra measurements. So what I did was I came from the femoral side and did a balloon occlusion with that 12 millimeter tie check that was on the table, and made then a proper injection through the 5 French flexor sheet that is in the portal vein. And so that you can see right now, and you see exactly where the left portal vein starts. Okay, so in the meantime we did prepare our 12 French, the 12 millimeter vascular occluder 2 to be inserted through the 5 French flexor sheet. Okay. Can I have the pedal? The pedal.
Okay.
Oh, I can give it to Björn. We're gonna shift hands a little bit. I did leave a 4 French vertebralis catheter coming from the groin, so that we can really check that we are in a perfect position. Give us vastskopie. Okay, vastskopie.
Kunnen niet kopiëren.
No scopie. Please have scopie.
Ja.
Okay, so the wire comes back. Hups. We go in with the device. I must say that those vascular occluders, they are not that, this one now goes easily through the 5 French sheet. The way it's delivered, it doesn't fit the valve of the flexor. So we're gonna, here's my device. I must say it looks terribly ugly.
Very good.
It should be somewhere there. So we will pull it back. See what that is gonna do. Oops. Okay. Pull back a little bit the other catheter, Peter. Pull back and make an angio. No, under angio. Angio.
Ja, je hebt hem vast. Hè?
The pedal? You have the pedal? Yeah, angio. I'm checking for the left if it's there, because indeed our distal disc, we want to have it proximal, distal from the left portal vein. It looks like we are too. It looks like we're too distant. Wait. Scopie en vast.
Looks good to me. Depends on how long the device will be if you push it out completely.
Well, we are not seeing the left vein at this moment. New angio.
I think you do
Angio,
see it.
film it.
You do see
Film
it
it.
where the catheter is now. Your disc
Okay,
is more close to the
we're
heart
perfect, we're
than the tip
perfect.
of your catheter.
That's-
There you go. You're fine.
Okay, we're fine. Open maar. Hè. Okay. Ja, scopie. Op vast. So we leave the distal disc in place. We just open the proximal part. The catheter is out. Angio. We're out. Okay. So there's no way we have now to control that, but angio it again. It apparently did not move.
You check through the sheath.
It did not move. I think the distal.
Check through the sheath. You'll go through the device.
We can try it. Give us een goede flush. Real flush. Push the sheet against it. Okay, angio, full angio. Okay. I think the device looks all right. It was distal from the left hepatic
so too.
vein, and there's almost no way we could have advanced it. If anything, it will have come back. So we will unhook this device.
Show the last angio when the catheter was still there.
Say it again.
Mark, it's a fantastic result in my opinion. The position of the devices, in my opinion, is in the right place. But don't you think it could be a very good idea to maintain the wire through the sheath, perhaps using a bigger sheath, in order to maintain the stability during the deployment procedure?
Say it again.
No, normally when I do this kind of closure, we are maintaining the wire in the same sheath coaxially in order to maintain the stability, and we deploy completely the devices, and after this withdraw the wire. In this way, normally the stability of the sheath could be better.
You might, but it will cost you a French size. And so this is a 2-month-old kid. It already has a 5 French sheet in the neck. Probably you can do it, but I prefer to be as nice as possible to the neck veins. I'm afraid that we may need them in the future. As I said, I don't like at all those collaterals. It's definitely so that the portal system is not normally developed in this patient. I think this patient will come back, and then we will have to look through the arterial side, or even with direct puncture, go to the hepatic, to the portal vein, and take it from there in the next couple of months. In the meantime, we will unhook. Give the. Is hij klaar? Komt tot hier. We will give copy because we have to leave the satellite.
Yeah. The satellite will be away in 1 or 2 minutes.
Okay, we just unhook.
This was a great case, is still a great case. We have to go back to San Donato as soon as you release the device.
It's released.
Yeah, so this was the end. I think this is a great case. Give him a clap.
Okay, thank you very much.